So you can tell the difference between normal with the dysplasia, like you can see kind of the difference.
Oh.
Now, this gets tricky because you'll have a whole cluster of cells that are neoplastic, and with the whole cluster of neoplastic cells, how can you determine if it's benign or malignant? What happens, the benign cells kind of look more to the tissue type, whereas the malignant cells are not, they don't look familiar to the tissue type. You understand what I'm saying?
Uh-huh.
So, perfect example is the leukemias, okay, the acute and the chronic. That you can tell, okay, which one is more of immature and mature. So whereas something that's more malignant, when you look at those cells, and we don't have to worry about, because we're not doing pathology in that sense, but if you look at those cells, you can't tell, okay, well, this is breast tissue. But if you look at a benign cells, you can tell. The benign cells, you can tell that, okay, well, this cell has more features of breast tissue, so even though we know it's benign, but yeah, okay. And we'll get into that in a second because that's part of chapter 7. Okay, now, irreversible cell injury, this is now when we talk about necrosis and gangrene. Okay, so necrosis and gangrene. Now, make sure you go over, nothing really special with this, just make sure you go over the 4 different types of necrosis and the 4 different types of 2 different types of gangrene. I'm sorry, there was 3 different types of gangrene. And those are pretty easy and simple. There are also pictures associated with this, so just make sure you know that. I'm just trying to think here how this could tie in. One thing that I will say about this information, anything that has to do with a lack of blood flow, okay, or decreased circulation will result in a dry gangrene. Anything where there's a lack of blood flow, I should say to tissues, okay, to tissues or extremities. Anything that there's a lack of blood flow, internal organs, is going to be more of a wet gangrene. Okay, so just keep that in mind. And the reason why I'm saying that is because if a person has, say for example, a volvulus that's complicated, okay, a complicated volvulus where they're now having not enough blood flow in that area of the intestines, what type of gangrene? It won't be a dry, it's going to be wet, okay, because of the type of tissue. Okay, so that's that. Okay, so we're done with 4. Let's see anything else. Are you guys okay with this review? Is it too much or not enough? I'm trying to get it as detailed as possible. Just looking at my time here. We'll have enough time. Okay. So, chapter 7 talked about neoplasias. So with neoplasias, this information is pretty straightforward, okay, I believe. Keep in mind that this information with chapter 7 will be incorporated with different types of cancer. So we've gone over certain cancers in detail, such as we've gone over testicular cancer recently. We've gone over prostate cancer, colon cancer, okay? So some of the cancers that we've gone over in detail, how you should use this information with chapter 7 is just plugging that in, okay? So with chapter 7, the main focus is make sure you know the difference between benign and malignant, okay, cancer. So in the beginning, we talked about the difference. And in your book, I'm glad you pulled this up. In your book for that chapter, chapter 7, there were 2 charts, okay? Table 7-1 and table 7-2. Make sure you go through those tables and know the characteristics of benign and malignant and also the nomenclature. Okay, so this isn't new stuff. You guys know this already. Make sure you go over all the risk factors. Make sure you also understand the physiology of tobacco use. I believe I will have a question. I'll try to add in a question with that. Keep in mind the tobacco use and the types of carcinogens tobacco use has and how that affects these cells. That's really important to know. The other thing you should know is the warning signs of cancer for adults and children. Then we also had grading and staging. And then the last thing with this chapter, we went over treatment and then the effects of cancer. Okay. Now, what are some effects of cancer as far as conditions that we've gone over so far throughout the term? Okay, anemia. Say that again. I'm sorry, I couldn't hear you in the back. Hair loss. Okay, now along with hair loss and talking about the dermis, what else can happen? There's a condition that we talked about in GI. There's a condition that we talked about in GI that goes with this type of thing as far as an effect of cancer. Not ulcerative colitis. Ulcerative colitis could lead to cancer, but not the other way around. Stomatitis. Remember the lesions in the mouth? Okay, so cancer patients can have stomatitis. They can have an anemia. We know that they can have definitely bleeding disorders. Okay, so everything that was with, what chapter was it? Chapter 12? No, not chapter 12. Chapter 14. Okay, so all the coagulation disorders, okay, those things. So just keep that in mind. Okay, just go over all of those things. Okay. Now, week 2. Now, with chapter 11, with the leukemias and the lymphomas, a lot of people, I shouldn't say a lot of people, but some people found this difficult, that particular test, and some people found it easy. For the most part, I think a lot of people had some issues with it. I thought it was straightforward. The way you should study for chapter 11 is straightforward. Just make sure that you know the type of leukemia it is, whether it's the immature, mature phase. Make sure you know the picture associated with it. Make sure you know all of these signs and symptoms and the treatment. So it really goes in that nice little outline that I showed you in the beginning. This is one of the chapters I feel in your book as far as the PowerPoint that's laid out precisely the way it is with the topics. There's nothing in particular that sticks out with me that I could say, okay, well, this ties in with this or that. Keep in mind that a person with leukemia, just keep in mind all of the effects of cancer that go along with it. So just kind of go over, I would add that in, okay, as far as any extra material for chapter 11. So maybe a person with a CLL, they could have a stomatitis, or they could have some GI disturbances, okay, or something like that. So those are just some things that you probably could add into that. But other than that, I think it's very straightforward. Keep in mind that your laboratory values will also be used for this chapter, chapter 11. So we went over the white blood cell count and differential. Also, definitely looking at if the patient has an anemia. So looking at the red blood cell count, Okay, so keep in mind of the laboratory values that should be in place with this chapter. So again, there's nothing to really pinpoint with it, but those are the things that I would highlight. I would also highlight the leukemias and lymphomas that share signs and symptoms, and I think I talked about this before. So the ones that share fever, the ones that share sweats, the ones that share bone pain, okay? So I would, when you're studying, just try to make maybe a separate chart, okay, with that, and go over the signs and symptoms they share, okay, because it could be a question, something like that. Any questions so far? Okay, if you want to stop me and you want me to go over something, just let me know. Chapter 12, again, not a lot of information with chapter 12. This one should be very easy to you. When we talk about HIV and AIDS, there's just a few things that I wanted you to know. Obviously, the modes of transmission and prevention. Make sure you know the protocol for healthcare workers. That's important to know. I think I had a question like that before, and I'll put another question on the final, making sure you know the protocol as far as the hours, okay, and the administration of the type of medication that should be given. And what else? Make sure you also know the 3 different types of testing. And also making sure you know the 3 categories, okay? So remember, we have category 1, 2, and 3, and the CD4 counts that are associated with those. And make sure you know the diseases that are associated with those categories. And please keep in mind, and I've had questions like this on the previous test, please keep in mind those AIDS-related diseases, okay? So keep in mind, I believe I told you guys which ones to highlight. There are some diseases that are AIDS-related only, okay? So, and there were questions like, okay, well, how would you explain to the patient what they're going to start to see and things of that nature. So what is 1 or 2 AIDS-related diseases that you know? Very good. Kaposi sarcoma, which we know is only an AIDS-related cancer. What else?
Recurrent pneumonia.
Very good. Recurrent pneumonia, and especially the pneumocystic gyrobacter, okay, which is the most common pneumonia in those individuals, okay? So just keep in mind that you need to go over those, okay, age-related diseases. Okay, so that was week 2. So now we're on week 3. You guys need a break, or you okay? Chapter 14 went over the alteration in hemostasis and blood coagulation. So with this chapter, we went over all the different types of blood disorders, okay? Now, first off, in the beginning of the chapter, it just went over normal hemostasis process, okay, which I do want you to know. If you know the normal hemostasis process, I could have just normal physiology questions on this, or just understanding the process so you'll understand the diseases, the questions on the diseases, okay? So, you help me walk through this, okay? So say, for example, I cut myself and I'm bleeding. What is happening? Okay, before we clot, what's the first thing that's going to happen? Very good. Vasoconstriction. Please make sure you understand that the vessel will constrict, okay? Just like if you were to, it's more like a compensatory mechanism. If you were to touch something hot, you would do this, or something touches you, you curl up, okay? So it's the same situation. So the vessel realizes, oh, it's broken, we're bleeding, we want to stop the blood, so it is definitely going to constrict, okay? Number one thing. What is the next thing that happens after vasoconstriction? Platelets, very good. So platelets will come to the area and block up that opening and form the beginning of the platelet plug. Once we have the platelet plug, what happens from there? fibrin clot, very good. Fibrin will then get activated to cover up that situation. Now, before we get to fibrin, there's not really another step, but what is happening when platelets come to the area? How do platelets get signaled to come to that area? Very good, the factors. Please keep in mind that platelets, they know to go there, but then in order to attract more platelets, the coagulation factors actually signal these platelets to come to the area, okay, to form a bigger platelet plug. This is one of the reasons why it's important to have coagulation factors, okay? As you know, when people don't have coagulation factors, it will not allow those platelets to go there, therefore leading into a bleeding disorder, okay? So, very good. Now, we left off at the fibrin, so yes, once we have the fibrin is just a net that covers that platelet plug. And then once everything's nice and healed, what happens from there?
Fibrinolysis.
Very good, fibrinolysis. We have to break down that fibrin, okay, because we don't need to keep that clot there. If we keep that clot there, then what do we have? If we were to keep a clot there, what will happen abnormally? A blood clot, also known as a thrombus, okay? So if we were to keep that there, that would turn into an abnormal blood clot or a thrombus. Make sure you also know bleeding time. That's not on the laboratory sheet, but I will need you to know that for the test. So bleeding time is going to be anywhere between 3 to 9.5 minutes, or, well, 3 to 9.5 minutes is your bleeding time, okay? So make sure you know that along with the other coagulation testing. Okay. If you are assessing a patient for coagulation disorders, what are some things that you would be concerned about in their history? What are some things that you would ask a patient? Very good, family history. Okay, so some people do know that they have a known history of whatever type of disorder. What else?
Smoking.
Very good, medication. Medications such as aspirin, okay. What else?
Smoking, diet.
Very good, smoking. Diet. One thing in the diet that they shouldn't have in their diet that could cause an issue. Alcohol, very good, alcohol. So not so much just a restricted diet, but if they have alcohol in their diet, okay, as far as drinking a lot, that could be an issue. What else would you want to know? Think of all the things in the patient history that you think you would need to know if they're having a bleeding or you want to check for bleeding disorders. So as far as medication, let's go back to that. We went over aspirin, yes, and then even some of the NSAIDs, okay, so that's also important. What else as far as medication? Very good. We want to know if they're already currently taking anticoagulants, okay? That's important to know because you don't want to give them more anticoagulants if they're already taking some, and that can also cause bleeding issues if it's not regulated, the levels. And another thing that you're missing from the history is making sure that they don't have any type of liver diseases. Okay, remember that most of the coagulation factors are synthesized in the liver, and if these patients have liver disease, this can also be a trigger. Okay, along with renal failure and cancers. Okay, so we went over the laboratory testing already with that sheet. Now the rest of this chapter, the only thing I can say, I'm not going to go through each and every disease, but the only thing I can say is please make sure you know what the disease is, okay, what it's doing to the patient. Make sure you know the hallmarks. I think there were certain hallmarks with some of the diseases. Make sure you know whatever type of laboratory testing that should be associated with it. And for some of the bleeding disorders, we didn't go into a lot of detail with treatment. because most of the treatment was just kind of making sure you take care of the underlying issue, what have you. But for those that have a detailed treatment, I would say yes, make sure you go over the detailed treatment. Okay. And that was pretty much it. Okay. So chapter 14 did not have any pictures associated with it, but it did have some laboratory values, okay, that we'll have associated with this. Chapter 15, there were only a few things we went over with chapter 15. Now again, and I said this before, for chapter 15, if you need to review your normal physiology of blood flow, please go over that. And that's the beginning of that chapter, although I don't have any particular questions towards it, but for those people that may not understand velocity and flow and so forth, just make sure you go over that. Now, with chapter 15, there were only a few things that we highlighted, okay? Thrombosis, embolism, we went over Berger's disease, Raynaud syndrome, aneurysms, varicose veins, and DVT. Varicose veins and DVT. Now, what's the difference between a varicose vein and a DVT? What are some differences as far as maybe history or risk factors, or I don't want to say the exact cause, but some of the risk factors for varicose veins and DVT?
DVT is associated with smoking.
Okay, very good. DVT is associated with smoking. That's one risk factor. What are some other risk factors for DVT?
Oral contraceptives.
Oral contraceptives, very good. And one main thing with DVT, which causes the situation? Prolonged sitting. Okay, prolonged sitting. Please keep in mind that DVT is associated with prolonged sitting, whereas varicose veins is associated with prolonged standing. Okay, it's two different risk factors, and I think people got that confused on the test. But DVT is prolonged sitting, whereas varicose veins is more prolonged standing. Okay.
So then where does like chronic venous insufficiency, like, is that something totally separate?
Chronic venous insufficiency is a more complicated varicose vein. So it's where people get ulcers. Yeah, it is kind of separate. It is kind of separate, because what happens with that is they get ulcers right at that area. But it's not associated with a DVT or a varicose vein. It's just a whole separate issue with venous flow. Treatment. What would you do different for a person? Well, let me ask the question this way. If you have a patient that's hospitalized and you're going in and you're monitoring your patient that just maybe had some kind of surgery done, what are some things that you would tell them as far as maybe a restriction, or something that you would tell them, or something that you would do to kind of reduce the risk of them getting a DVT?
Reduce walking or like
Well, we don't want to reduce, well, we don't want to do nothing strenuous, but not reduce the walking, but you want to have them mobile. So if you have a patient in the hospital, maybe just had surgery, they're laying up, okay, and they're sitting there, what's happening is blood is not flowing, okay, as it should. So it's stagnant. So you want to try to get this patient moving about as much as they can, okay? So whether that's just kind of moving the leg around or getting them up out of the bed or whatever it is, but just kind of having them somewhat mobile as much as possible. Now, the other thing that goes along with that too, just to let you know with DVT, these patients should stay away from massages, okay? So sometimes patients will have maybe a surgery just done or what have you, and they, you know, the muscles may be achy or whatever, and they want to massage it out or whatever. They have to stay away from that, because if they do have some sort of thrombus or DVT that's present, what could happen? Embolus, very good. So a massage, somebody can go in and dig and it'll break off, okay? So that is a recommendation that needs to be taken care of with that. Now, what are some alternatives that people can do for varicose veins? Okay, so we did DVT, so what about varicose veins? What are some alterations that you could educate a patient on?
The compression stockings.
Very good. So the compression stockings, okay, so the compression stockings will now keep the vein nice and tight, so we don't have all this bulging effect that's going on, okay, and keep the flow moving.
Can compression stockings be also used for DVT?
No, I don't think.
Because I remember when people travel a lot and they're in the airplane and they see the.
Well, that's a different type of compression.
Okay.
If it's, because those compression, they have a compression mechanism that is like a pump.
All right.
But the actual stocking just kind of holds the vessel in place and it keeps the flow.
That's better.
But then they have another thing that's like a pump. That's a compression type of pump. That keeps the blood moving, even though when you're sitting. So compression stockings, and also you guys will definitely need to, with standing on your feet, making sure too that you wear proper shoes, okay? So you know those nursing clogs, okay, and especially the fancy, expensive ones, okay? Those are made not only just to help with your feet, okay, and the tarsal bones and all that, but what it does, it actually keeps the leg in such a position where it helps the flow and not so flat, okay, and especially when you're walking, because those floors are very hard, okay. All right, so that's that. Okay, so that was that with 15. Okay. 16, we just basically went over blood pressure with this chapter. A couple of things I just want to highlight. Make sure you know, as far as blood pressure measurement, the direct and indirect ways. There's 2 ways to measure blood pressure, direct and indirect. Make sure you know the difference between short and long-term regulation of blood pressure. And in particular, we talked about the ACE inhibitors, okay? So make sure you know the medications that are associated with blood pressure. So we talked about ACE inhibitors. We also talked about beta blockers. And we also talked about Lasix, water pills. What's the other one? Diuretics, thank you. Diuretics. What that is, because the sound isn't on. So anyway, with hypertension, make sure that you know the categories. So what's normal, pre-hypertensive, stage 1, stage 2. Please make sure you have that memorized and know that forever and ever. Okay, so that is the standard classification, not only just for this book, but even when you go into any of your nursing classes. Now, as far as hypertension, please make sure you know the difference between primary and secondary. Obviously, all the risk factors, the ones that are modifiable and non-modifiable. And the other thing here with hypertension, make sure you know end organ damage. The end organ damage of hypertension. So yes, hypertension, we know, okay, yes, people, hypertension, but then what is the issue? So what are some examples of end organ damage of hypertension? I'm sorry, say that again.
Heart failure.
Okay, heart failure, yes, very good. This can now give them heart failure. What else?
Kidney failure.
Kidney failure, very good. What else do people get with hypertension? What is one common sign or symptom that people get with that are hypertensive? They could pee a lot. It depends on the medication. Sometimes that's from the medication, though. Headaches. Okay, keep in mind they get headaches a lot. This could lead them into a stroke. These patients could have a stroke. And they can also have retinal hemorrhages, okay, in the eye. So make sure you go over all of the things that can happen with these individuals, and that is listed in your PowerPoint. Okay, if you don't mind, that's pretty much the first half of the class. If you don't mind, I need to take a little break, and then we'll come back and finish up the rest.